Hello everybody, welcome to Module 2. Concept is reproduction, but the topic will be specifically regarding pregnancy. Again, my name is Lynn Whitmer, lead instructor for maternal child health. We're going to cover chapters 5, 7, 8, 9, 10, and 11 in this PowerPoint. If you have any questions or concerns, please jot them down, then send an email to me at any time, and hopefully I'll get back to you. So let's get started. First of all, your objectives are available to you, so I will not read these. You can go ahead and read through those in the module itself. Let's begin with the process of pregnancy. We alluded to a few things the other day in orientation, but I want to clarify, restate some of the issues. First of all, pregnancy is all about timing. As noted in your textbook, the ovum of the egg of the female, the ovum, which is the egg in the female, only lives for 24 hours. So there's a very short, small time frame in which, indeed, this egg is going to be viable to be implanted, fertilized, implanted, and then grow a baby. The sperm live for 2 to 3 days, but then they have quite a journey to make to get to the egg to fertilize. They come together and meet in which is called the ampulla of the fallopian tube. When we're looking at internal structures of the body, we will be talking about the fallopian tube, and it is specifically, there are 2 of them, one on each side of the uterus, and they're specifically for transport of the egg, transport of the sperm. That's really all they do. What can impede that transport? Scar tissue. Scar tissue can come from chlamydia, gonorrhea, or any other STI infection. If indeed there's an impediment of the transport of that fertilized egg, because it's going to continue to grow, we'll have an ectopic pregnancy. We manage ectopic pregnancies either through chemical or surgical intervention. And we'll talk about that later as we talk about some of the critical components. Once the egg is fertilized in the ampulla of the tube and it starts to move, remember it is continuing to divide. The cells are dividing and it becomes what we call a morula, a 16-cell globule, which can be seen with the eye, and it will land itself in the uterus. Inside the uterus, because of the influences of the hormones, during the menstrual cycle or prior to the menstrual cycle, we've had a lot of estrogen and progesterone influence, which has caused the endometrial lining, or the inside of the uterus is the endometrium, to get very thick and lush and prepare for the egg to land there. When this happens, the egg kind of burrows itself down into that nice, lush lining, and it may cause a little bit of bleeding. If you think about this, we know ovulation occurs, and then 14 days later we have menstruation bleeding. So if we have some menstrual bleeding or vaginal bleeding at 10 days, we may think that it is just indeed a light, off-kiltered period, menstrual bleeding, and don't take much notice of it, and lots of times then pregnancy goes unnoticed, and we are pregnant and we're not aware of it, because when the egg embeds, there will be some implantation bleed. The hormonal influences are human chorionic gonadotropin, which is HCG. That's what we pick up on our little pea sticks. That's what we find when we do a serum draw. We find human chorionic gonadotropin, which helps support the pregnancy until the placenta takes over. Once the placenta takes over, estrogen and progesterone are critical, and they are developed, they're manufactured and excreted from the placenta itself. You're going to find that the placenta is a pretty marvelous organ. It is essential for the growth of this pregnancy, and we're going to talk about everything about the placenta. That is one of the parts of the module that I've given you. If you also recall from the very first module explanation, progesterone is the most important hormone of pregnancy, progestation. If you do not have enough progesterone, the pregnancy will not be viable and will not survive. If a woman has multiple losses or miscarriages, oftentimes we can link it to a lack of or a decrease in the amount of progesterone that she is manufacturing and excreting. So we can supplement that with either suppositories or injections. Remember, there's no fetal connection to mom for the first 15 days. We talked about that in orientation. But after the 15th day, approximately to the 60th day, that's the organ development period, the embryonic period. This is what we call the critical period. anything can cause an insult to that developing baby, and depending on when that insult occurs, we might have some anomaly, or some lack of, or some loss. What are some of the risk factors that can cause organ development damage or interruption? We know that drugs that mom is using, alcohol, smoking, poor nutrition, safety issues, toxins that she may be ingesting that unbeknownst to her, radiation possibly if you're working in the x-ray department, gases from the OR possibly, autoimmune diseases, hypertensive diseases, connective tissue diseases, diabetes. All of these things can have some impact on the developing organ, and so it's amazing to me that we have so many babies born that are healthy and intact with no outward or obvious anomalies noted. Some of these are known, some of these are unknown, and we're going to talk about preconceptual counseling in just a few minutes. Anatomically, where is the fetus located? We know he starts out in the fallopian tube as that multi-cell egg, and he migrates through until he hits the uterus, and that's where he'll be, is in the uterus. Where is it also noted? Please note that the uterus does not really start to grow much until a little bit later, and so it is well protected, well hidden in that bony pelvis, way down in the pelvic area. So we're going to be talking about some of those pelvic structures in just a minute. First of all, I want to review with you some terminology so that as we're discussing things and I start using some terms, I want to be sure that everyone is on the same page. Fundus is the word for the top of the uterus. It is the thickest part of the uterus. It's the part that we're going to palpate antepartum, postpartum. It's the part of the uterus that pretty much starts that whole cascade of contractions when labor begins. Gravida is the number of pregnancies. Parity is the number of deliveries, be they live or dead babies. Okay, let's not have any misunderstanding of that. So if someone is pregnant, chooses to have an abortion, she is a gravida 1, para 0, because she never delivered a viable pregnancy. She miscarried or had a terminal loss prior to the 20th week. 20 weeks is viability, medically. When we look at gravity and parity, we should also talk about the 5-letter mnemonic, 5-letter abbreviation that is used to determine the full obstetrical history. We'll talk about this again, but let me mention it here. We have a G for gravity, we have a T for full term, or an F for full term pregnancy, meaning the pregnancy went beyond 37 weeks. We have a P next to that for preterm, meaning a pregnancy from the 20th to the 36th week. We have an A that stands for any abortions. Now, abortion is a medical term for any loss, be it spontaneous or elective, doesn't matter. And the last letter is L for living. So those numbers don't necessarily always add up. Those numbers can be very varied based on the obstetrical history this patient gives you. The other thing I want to mention about your 5-letter abbreviation is it does not matter how many babies or how many fetuses are inside the uterus for this pregnancy. It's still one pregnancy, one parity. So if someone has had 3 sets of twins and she's not pregnant right now, she is a gravida 3. Full term probably 0 because most twins are born prematurely. So gravida 3, full term 0, preterm 3, abortion 0, living 6. So you see those numbers don't add up. Okay, that's just an aside for you. We're going to talk a lot about the placenta, but I want you to understand that at no time does mother's blood and baby's blood ever connect. There's a one cell layer of tissue that separate the baby and the mommy's blood. There is a gas exchange that takes place at the chorionic villa of the placenta. So if the molecule is small enough, it will pass through. If it is too large, it will not pass through. For instance, sugar passes through the placenta, but insulin does not. Heparin does not pass through the placenta, but coumadin does. or warfarin does. So we have to know a lot about the medications, what passes through the placenta and what does not. Bacteria and viruses pass through. Caffeine, alcohol pass through the baby, to the baby. Now, your textbook suggests that some of the amniotic fluid has a semi-barrier to some of those viruses and some of the bacteria. It has some immune processes in it, but let's not rely on that a lot, because I've seen babies born with herpes. I've seen babies born with cytomegalovirus. I've seen babies born with chlamydia and gonorrhea and those other issues. So we don't want to use that as a total knowledge. We really want to caution women to protect themselves. LMP is last menstrual period, but please, you have to be very specific with your patients and note it has to be the first day of the last menstrual period. We use that as a guideline to determine estimated due dates or estimated date of delivery, which is your EDD. And we use, in our heads, we can use Nagel's rule. Dr. Nagel, he developed this rule of thumb that if you take the first day of the last menstrual period, you subtract 3 months and add 7 days, and you'll have a very close estimation of what the estimated due date will be. Now, this only works 100% of the time if the woman has a 28-day menstrual cycle, and we know that very few women have that. So it's going to be off a few days, but at least you have a starting point to begin your discussion with your patients when you're first meeting them. Ultrasound is a great tool. We use it a lot. We use it for exacts, but you do not have access to ultrasounds. Remember that. So in discussions, you have to use other tools. And one of the tools is your brain. The other tool is your hands and your eyes. And of course, use your sensitivity and your compassion when you're discussing things with patients as well. So without the modern tools, the electrical tools of ultrasounds or other devices, we have to guesstimate estimated due dates by using Nagel's rule, using our fundal height, the ability to hear fetal heart tones, and ask if there's any fetal movement, correct? All right, let's move on to our second slide, or third slide. Anatomy. Let's talk about the anatomy now. And as we're going through your textbook, that's what it's doing. It's going to point out some of the anatomical processes. First of all, the bony pelvis. Ladies, you don't come with one specific bony pelvis. The most perfect pelvis is a gynecoid pelvis, but most of us have what we call mixed pelvises. And there are several different kinds, or I'm sorry, there's 4 different kinds, and those are pointed out on page 123 to you. So most of them have some very different nuances. And based on what we find when we do pelvimetry on our physical exams, we can guesstimate, and it's only a guess, again, a guesstimate that you will be successful in a vaginal delivery or not. The narrowest part of the bony pelvis is the ischial spine, or as you're seeing on this picture, the outlet, where the ischial spines are the narrowest. The baby's head has got to come through that part, and if the head is larger than that length between the ischial spines, he's not going to fit. And when he doesn't fit, we call that CPD, cephalopelvic disproportion. In lay terms, we call it BNCO, baby no come out, but we can't use that term in the medical world. So the bony pelvis, we know that it protects this growing fetus during its critical period because that's where the uterus is at. So it's really going to protect. The muscles, again, you will see on page, I apologize, when we go back to page 116, you see a schematic there of all the musculature. Please understand that the pelvic organs are all free-floating. They're not fixed, what we call fixed, because if they were fixed, they wouldn't grow as well. And the ovary has to be free-floating, and the fallopian tube has to be free-floating for all these things to work together. Otherwise, they'd be sticking together, and we don't want that. So the uterus is relatively a free-floating organ, except for a few ligaments that you see on the next page there. You see the broad ligament, the round ligaments, the ovarian ligaments. Those ligaments help attach the uterus, but it still is a relatively free-floating. In the non-pregnant state, the uterus is kind of folded over in half. It either faces the front or the back of the female anatomy. So it's either anteverted or retroverted. Neither one makes a difference in the ability to become pregnant. It only makes a difference during intercourse or during your menstrual cycle because it can be a little more painful. So as you see, the egg is released from the ovary, it floats to the fallopian tube, and then the fallopian tube then is transported into the uterus, where inside the uterus there, you see it is relatively hollow. The endometrial lining gets very thick. We have 3 layers of the uterus. We have the endometrium, we have the myometrium, which is the muscle layer there, and then we have the peritoneum, which is the outside of the uterus. You can see that the muscle layer is very thick right now. And it actually is about the size of your fist, non-pregnant, but it's very, very thick. During the process of pregnancy, that layer thins. It still is there. And in fact, the fibers actually multiply, but they thin. And that is how the uterus grows. Hence, when the uterus is large enough, and it's way up in the abdomen now, it has migrated up into the abdomen, we can feel fetal parts because the uterus is thin enough to allow us to feel fetal parts. But that's not going to happen until about 28, 32 weeks gestation. So don't go looking for fetal parts. Much prior to that, you'll feel fundal height, but you will not be able to feel fetal parts. It also impedes our ability to actually hear heart tones until that muscle lining has thinned enough for the Doppler, for the sound waves to actually get through it to resonate onto the baby's heart. Please don't negate the idea of the bladder as well. The bladder is a very important organ, and as you can see on page 119, the bladder is really larger than the uterus. But because most times the uterus is falling on top of the bladder, as it starts to grow and get thick and heavier, it puts a lot of pressure on that bladder. Hence, pregnant women in the early stages feel like they have to pee all the time. It's most annoying. I'm back to the bathroom, I'm back to the bathroom, I'm back to the bathroom. The rectum also gets pushed on and pulled on. Please understand that the uterus takes ownership of the abdomen as it starts to grow, and everything else has to move out of the way of this growing baby. When we talk about some of the other external organs, the introitus to the vagina, I don't know if we're actually seeing a picture. Again, I guess we go back to 116. You see the urethra, the vagina, and the rectum. Around the rectum, the vagina, and the urinary meatus is what we call the bulbar cavernosus muscle. It's a figure 8 muscle. It's also what stretches and gives and gets cut during the vaginal delivery if necessary. And as I was saying, everything is free-floating, so the only thing you have holding these organs in place is that muscular structure, which is like a sling. So we want to do our Kegel exercises to help maintain that sling, to keep all of our organs up in the proper position. If we don't exercise that muscle, it's going to get lax and loose like any other muscle of your body that's not used. So be doing your Kegel exercises, lady. In fact, if I did a poll right now, I bet you're all doing one. Very cool. All right, so the function of the uterus, we talked about the multiple layers and how it grows. The purpose of the uterus is two things, cyclic menstruation and housing. It's just a receptacle for the egg. That is the only purpose for our uterus. So if you never get pregnant, you've only used it for half of its purpose. Okay? When we talk about breasts, which are also part of our sexual organs, there are only 2 functions to the breast. That's for sexual activity and as for lactation. And most women use it for the former and not the latter, and that's on them. We're going to talk a little bit more about breasts as we talk about some of the changes of pregnancy. At the bottom of the uterus is the cervix. It is really kind of the opening to the uterus. The cervix has an endocervix, which is the inside of the cervix, and an ectocervix, which is the outside. And during a pap smear, we want to get some cells from both of those to ensure that there's no cancer growing on either end. You can see on page 120 that the muscle fibers kind of crisscross across the uterus, so it's very important to understand that those muscle fibers are working in concert together when it is time to expel the baby. So that is another function of the uterus, to expel whatever is in front of, or inside of it. And those muscle fibers have been built, so they're very powerful and are able to expel this growing baby. The vagina is a collapsible tube, and because of good nutrition, staying away from bad influences of smoking, drug, or alcohol, we have heavy-duty, expansive rugae inside the vagina, which are healthy, and allow the vagina to stretch. It will accommodate anything going into the vagina and anything coming out of the vagina. Now, if you have not taken good care of yourself, have poor nutrition, use drug, alcohol, smoke, then that tissue is not going to expand and you're going to have a lot of tearing going on during the vaginal delivery. So we caution women about that. The other thing is lactobacillus, which is a normal bacteria we harbor in our genital tract. We want to have that. If we're not eating goods, we don't have a lot of lactobacillus, and that allows some of the abnormal bacteria to harbor and grow, such as yeast, flu cells, some vaginitis. We have little bits of things which are not necessarily an STI or an STD, but they're annoying and can cause some problems. And it will not allow the vagina to stretch. The perineum is that space between the vagina and the rectum. It's the perineal body, and that's what's also going to stretch, like we said, and allow for that baby to be delivered. The internal structures, we've already talked about the vagina, we've talked about the fallopian tubes and the ovaries, we talked about the uterus, the fundus, the cervix, and we've talked about the bladder. So I think we've mentioned all of our structures there. The traveling ovum, as we said, it lives for 24 hours. Sperm lives 3 to 5 days in the other textbook I was using. Fertilization happens in the fallopian tube. We've already mentioned that, and implantation causes implantation bleed. And you see on that picture, to the left of that picture is where the chorionic villi are going to attach. This is a 13-day-old pregnancy, and where it's really rough on that left side is where it's going to attach to that endometrial lining. And it's through that chorionic villi that we have the gas exchange. At no time does the placenta feed the baby. At no time does the placenta provide oxygen for the baby. But the placenta does do a lot of really nice, cool things that we're going to talk about. The pregnancy in itself is 280 days, and that is from LMP. If we know the actual conception date and time, we can say the pregnancy will last 266 days. Here is the placenta. We do need to spend a little bit of time on the placenta because it is the most important organ of pregnancy. If your placenta is not functional, the body will not maintain the pregnancy. And as I'm perusing through the rest of Chapter 5, I see that they're going to discuss the menstrual cycle again, which we've already kind of discussed and talked about. If you want more explanation about that, I'm happy to spend any time with any of you on the menstrual cycle. But when we're looking at the total body of knowledge you need to accomplish this quarter, that's not the most important. It's important, but not the most important. Chapter 7 begins with genetics, and I don't spend a lot of time on genetics. Please just understand that everybody brings a unique set of genetics to the plate or the table, whatever you want to call it. And when you bring chromosomes from the mom and chromosomes from the dad and you mix them together, we get quite a different construction each and every time. We are unique individuals, unique beings, all with our own DNA. We've identified that by watching all the detective shows. You probably recognize that. So I find that somewhat fascinating. But the study of genetics itself, I'm not really interested in. If you are, I would encourage you to go ahead and study that. There are great opportunities for nurses now to go into that field to help people, because some women are waiting much longer to have babies, and once you hit the age of 35, our chromosomes do start to wear out a little bit, and our genetic material is a little more aged, and so we have bigger risk factors. So it's nice if we have nurses who want to talk to patients about that. So the placenta itself develops once the egg has implanted into the uterus, and the placenta is part of the genetic makeup and will migrate itself away from the rest of the cells and then develop. Its structure is what you're seeing in that picture. In the very bottom picture, you see the maternal side of the placenta, and it is filled with cotyledons. There are 15 to 20 cotyledons, or beds of vessels, that will then get close to mom's endometrial lining, and the gas exchange takes place through that. On the other side, or the fetal side, which is on the top left of that picture, is the amnion and the chorion. The amnion is the layer that is closest to the baby, and the chorion is the layer that is closest to the mom. The amnion and the chorion together are translucent. You can see through them. They're two layers is all they are, and yet they are the toughest material. You cannot break through those with a soft object. My finger will not break through the amnion and chorion. Now, a sharp object, absolutely, you can cut into it, you can break it, and we do that in labor to help augment labor. But if you're just trying to play with the placenta and you try to push your finger or push with all your might through that, you cannot break through it, which is amazing to me that this is a two-layered structure that is so strong, and it has to be to help encapsulate that baby. Remember, the baby's like in a balloon now. Now, the cord should connect to the center of the placenta so we get the best blood volume at that part. The cord then connects to the baby. This is their umbilical cord. The umbilical cord has 3 vessels in it, 2 arteries and a vein, and it is reversed from what you understand. The vein takes oxygenated blood from mother to baby, and the arteries take deoxygenated blood back from baby to mother. So the placenta acts as a conduit or transport of nutrients, of oxygen, and of waste products. But it doesn't do any of those things directly. So if the question comes up, does the placenta provide nutrition? No, it does not. It provides a means for nutrition. Does the placenta protect the baby from viruses and bacteria? No, it does not, because there's a gas exchange, and if those viruses get through that gas, or through those vessels, it's going to make it. All right, so some of the function that the placenta does has, it's an endocrine function. It provides HCG to help maintain the early pregnancy. It provides HCS, which is a growth hormone, and it also provides insulin resistance so that mother stores more of her sugars, because at about 27, 26, 28 weeks gestation, the baby starts to grow. All the development is done, and now he's going to grow. And to grow, he has to have sugar, so mom starts dumping in all this stored sugar that she has. It's not quite that simplistic, but it gives you the idea. It also produces the estrogen and progesterone, which again, estrogen is your growth hormone and progesterone is your acquiescent hormone or your quieting hormone or your thickening hormone to make things much more workable. So it acts as a respiratory, nutrition, excretory, and storage facility, but it does none of those things directly. Please do not confuse that. Well, it crosses the placenta, just about everything. One cell separates them, and if we have a decrease in placental function, what's going to happen to your baby? It's not going to grow. And we're going to have another issue that we'll talk about. Hence, we do fundal heights each and every time we encounter a patient, because we can't see the placenta. We have to rely on what we can see or palpate or observe to identify what the problem is. This is a picture, a cross-section of a placenta. You see to the left of the placenta is the fetal end of things, and on the right side of the picture is the maternal end, and you can see where that gas exchange is taking place at the chorionic villi. All right, so the placenta is hugely responsible for everything. If something goes wrong with the placenta, if something interferes with the placenta, if something interferes with perfusion, which is a huge concept for this quarter, the perfusion, then this baby either will not survive or will not get the best outcome. This is what it looks like inside if you're to look at the baby in his little bubble there. There's the amnion and the chorion, and you can see the outline of the baby, and you can see the umbilical cord. So what's it like inside? This is inside the uterus. There's this bubble, and there's the amnion and the chorion, which we said in the amniotic fluid. Now, according to your textbook, the amniotic fluid is about 800 milliliters throughout the pregnancy. It does fluctuate a little bit. Initially, it's not that much, of course, but then as the uterus grows and as the baby grows, there's about 800 milliliters of fluid, and that's our normal. When we start to fall below 500 milliliters, when we start falling below 500 milliliters of fluid, we call that oligohydramnios. When we have identified oligohydramnios, we must think there's a problem with the baby's kidneys, fetal renal issues. That's the first thought. Doesn't mean that's what it's from, but that's the first thought we have. Then when we have too much fluid, we call that polyhydramnios. P-O-L-Y, polyhydramnios, and the first thought we should have is diabetes, because where sugar is, water follows. Remember that the umbilical cord has 3 vessels, 2 arteries, and a vein, and it is protected by Wharton's jelly. It's a jelly-like substance that cushions each of those vessels so they don't get crushed together or get restricted by activity or holding on or the tangling of the cord. The all vessels also intertwine amongst themselves, and you've probably heard the saying, 3 threads are stronger than 1, and so it's like having 3 entwined, and it does stay pretty strong because the baby's very, very active. If you watch an ultrasound picture of a baby and how active they are, it's surprising that the cord doesn't have more problems. So what does the amniotic fluid do for this baby? Number 1, it cushions him, kind of protects him from outside interference. It cushions the cord. It also allows the cord to float so that the perfusion of that cord is going to be never interfered with. It provides a constant temperature to the baby so that he's in a nice constant environmental temperature that will allow him to grow. He has free movement, which allows his muscles and his neurological system then to develop and to be healthy. And the 5th thing is that he swallows this fluid, and we can then identify that he has digestive functioning and renal functioning, because we can watch the bladder actually fill and empty. Your textbook also talks about lung maturity. This is part of it keeps the lungs from sticking together. So the lungs are now fluid filled to allow them to start to mature. What does the amniotic fluid not do? Again, it is not a protective barrier. It does not provide nutrition of any kind to the baby. Now, your textbook does allude to the fact that it has a little bit of immune ability, but it's not that great. Okay, so bacteria and viruses can still get to the baby. So that's the inside. This is just a review for you of what the placenta does. The very last line there, supine hypotension, you'll need to understand that. Please understand that if the mother lays flat on her back, number 1, she can't do it physically because she won't be able to breathe. So it's unlikely that she will do this subconsciously or in her sleep. She will wake up. But if she intentionally lies on her back, the weight of the uterus presses on the superior vena cava, decreases the amount of blood flow to her and to the baby. So she's going to get dizzy, she's going to get a little faint, and of course the baby is going to have some perfusion issues as well. So we want to caution women not to lay flat on their back. So yoga, you have to let somebody know you're pregnant if you're going to participate in yoga, or if you want to be laying on your back watching TV, or you have some back problems and it feels better to lay on your back, your pelvis still needs to be tilted somehow to allow the uterus off that superior vena cava. The best position for mom, if she's lying down, is on her left side. Left is best, right is okay, but never, never on her back. Okay, so if she understands our teaching, she will be laying on her left side or on one of her sides, and that's the easiest, most comfortable position usually for most pregnant women. As the baby grows, remember there are 3 trimesters. Preconceptual counseling, what is the purpose of that? It would be optimal if every woman came for preconceptual counseling before she became pregnant, but it's unlikely because most of us become pregnant and don't even realize we are pregnant, and it wasn't necessarily planned. If we have diabetes, if we have a hypertensive disease, or if we're not sure, it's really great to go in to get a physical exam and talk about pregnancy and what can I do to give my baby the best optimum environment. Start your folic acid, start your prenatal vitamins, start looking at your nutrition. Are you all caught up on your immunizations? What type of activity do you participate in? What's your job? What's your support system? Are you safe? Do you live in a safe environment? All of those things should be identified. So preconceptual counseling is about identifying risk factors to the pregnancy, number 1. Then it's about education. It is never our time to tell someone they should not or could not get pregnant. It is not our time to tell someone because they don't have the proper support system or they don't live in the right house to tell them they should or should not get pregnant. It is not our time to tell someone who has a brand new baby in her arms telling her not to get pregnant. We also need to talk about genetic issues. Is she aware of any family history of genetic problems, so that we can tell her what her risk factors are, and we also would look at age for the same purpose. So that's what preconceptual counseling is about. It's about identifying risks and then educating. What's our prenatal assessment supposed to be? Well, at our initial visit, when someone shows up and says she's pregnant, we need to do our historical data collection. She'll find out her age, get her name, find out what her immunization is, find out what she's been feeling like, let's find out if she has any allergies. Then let's ask past medical history. We ask family history, which includes the genetics. We ask obstetrical history. We would ask GYN history. We would ask nutritional history, surgical history. We would ask if she is safe. I've probably forgotten one in there, and if I have, I apologize. Then we're going to talk about nutrition, because nutrition is probably one of the biggest issues. What does she like? It has to start with a 24-hour recall. Encouraging her to take more B12, or encouraging her to increase her proteins, or encouraging her to do something else isn't going to work unless we're aware of what her likes and dislikes are. If she's a vegetarian, telling her to increase her red meat is not going to help. So just putting that out there as a blank statement doesn't help you. So let's do a nutritional 24-hour recall. Then let's talk about some lifestyle choices as well. Do you smoke? Do you drink? Do you think it's okay? Do you take in a lot of caffeine? Do you have to have that cup of coffee, that Starbucks every morning to get your day started? Do you have a problem with pica? Eating dirt, eating sand, eating cardboard, eating whatever it is that is a non-nutritive substance, which is going to take the place of nutrition, and that's the risk. Do you have a problem gaining weight? Do you have an eating disability? Weight gain has to happen. For someone at their ideal weight, as we've already said, 25 to 35 pounds. If they're obese, less than, and your textbook will probably talk about 15 pounds. In my practice, I had people not gain anything and still had a very healthy, growing baby because they were so morbidly obese. If they are underweight, of course, they need to gain up to their ideal weight and then an additional 25 or 30 pounds, which might be heartbreaking to someone who's thinking about having to gain 60 pounds. That's a little scary. Then we're going to have to help them find ways to do that. Who's their support system? Who's going to be with them when they have the baby? The father of the baby? Or do they have a different intimate partner? Or is it going to be their mom or a friend? Someone needs to support them through this pregnancy adventure journey and then as well through labor. Safety, environmental, we've already talked about. Their job, do they have a partner? Safe sex is important too. Just because you've now made an error, so to speak, and gotten pregnant doesn't mean you cannot introduce STIs if you are not careful or if you have multiple partners. So safe sex is now definitely important to protect this growing fetus, especially during that critical period. Medications, find out what prescriptions they are on, find out if they take any supplementation of any kind, then talk about over-the-counter. The only drug safe over-the-counter that I'm aware of is Tylenol right now, or acetaminophen. Motrin is an NSAID. It is not safe in pregnancy. What's their activity? Do they participate in combat or dangerous sport-like activity? Clothing. We want to ensure that they're wearing something loose that's going to grow with them. They've got some great maternity clothes out there nowadays. Nothing like what when I was pregnant. And they need to be aware of their physical limitations as this pregnancy grows. They're going to have some lordosis. They're going to have some gait issues, some balance issues. And so you got to think about that when they're choosing their shoes and what clothing they're going to wear, what type of activity they want to participate in. Labs. We're going to get labs with that first prenatal visit too, and I have given you a timeline within the module that I would encourage you to print and keep with you as kind of your cheat sheet, so to speak, and per week it's going to tell you what should be done. You're going to find that most of the labs are going to be done at the initial visit. The one lab that we need to talk about right now, however, is their blood type and RH. It's essential to have that. For anybody who's pregnant, you need to know their blood type and RH. we may need to give RhoGAM if she's Rh negative. If this patient is Rh negative, she will receive RhoGAM, which is a blood supplement or a chemical blood-like material that is given by injection, IM injection, at 28 weeks gestation for anyone who's Rh negative. If she has a threatened abortion or threatens to miscarry, or if she does terminate her pregnancy, she needs another RhoGAM injection. If she has an amniocentesis, she needs a RhoGAM injection. And after the baby is born, if the baby is Rh positive, blood type positive, she will again need another RhoGAM injection. If the baby's Rh negative, no, there's no need because it's an antibody crossover. Mom will start to develop the antibodies of that Rh positive blood, and it won't cause any problems for this pregnancy, but she may reject her next pregnancy. So RhoGAM, essential that you understand it and when it is given, and I will be asking questions about that. In addition to that, your routine assessments, your head-to-toe assessment needs to be completed, and of course a GYN or pelvic exam, which the physician or nurse practitioner will be doing. The diagnostics we include, probably we're going to encourage an ultrasound. If only one ultrasound is going to be allowed due to financial restrictions, then we will do that ultrasound between the 16th and 20th week gestation, is where we can find dating. We can date the pregnancy as well as get a great picture of anatomy. Please never tell me that we're doing ultrasounds for sex determination. We do not do medical ultrasounds for sex determination. We do medical ultrasounds for everything, and oh, by the way, we might be able to tell if it's a boy or girl, but it is not the reason for it. So if someone says, I want to have an ultrasound to know if I'm having a boy or girl, she's going to have to go out and pay for that. Other diagnostics, of course, the ultrasound, we might want to do an amniocentesis if indeed this patient has a risk factor for genetic risks. And we're going to see this patient after the initial visit probably every 4 weeks until she's 28 weeks gestation, then every 2 weeks until she's 36 weeks gestation, then every week until 40 weeks, and then twice a week until she delivers her baby. That is the routine traditional model of care. The other model of care that's being offered now is by midwives. It's called centering, where we bring a group of like gestational age together, teach them all at the same time. It provides a support, it provides education, it provides the ability to kind of bounce ideas, and they get to know each other very well. But we still meet with the patients on an individual basis to discuss personal issues. Remember, we talked about the 3 fetal well-beings, and one is fetal movement, and we know that that begins as of 16 weeks for a multiparous patient. This is not her first baby. For a prima gravida, someone that this is her first pregnancy, she will not feel the baby move until 18 weeks, and that's why we can say 16 to 20 weeks is our parameter for fetal movement. Fetal heart rate, we can audibly pick up fetal heart rate on Dopplers as early as 12 weeks. Sometimes 10 weeks if she's really skinny, but 12 weeks should be that outside parameter of when we pick up fetal heart rate, and we know fetal heart rate is anywhere from 110 to 160 beats per minute. And fundal height, we can start ascertaining fundal height with our fingers as early as 12 to 14 weeks. It should be leveled at the symphysis, at the umbilicus about 20 weeks, and then we use a tape measure after that, and centimeters equal weeks gestation. What would we think if we have a fundal height that is greater than what we expect? Our dates are wrong, she has too much fluid, she has a large baby, or she has more than one baby in her uterus. What would we think if the measurement is too small, less than what it should be for gestational age? Not enough fluid, poor nutrition has caused this baby not to grow, she has a hypertensive disorder that has caused this baby not to grow, she's been using drugs, she's smoking, anything that would impede the perfusion to the placenta. So then we start our investigation. The common discomforts of pregnancy, again, we said that pregnancy affects every part of the patient's body. So she might have headaches, fatigue, insomnia, increased salivation or sweating, bleeding gums, GERD, heartburn, nausea, constipation, hemorrhoids, shortness of breath, abdominal cramping, round ligament pain, carpal tunnel, sciatic pain, lordosis. Her feet get bigger. She might have joint pain, a little bit of cramping, edema, vaginal discharge, which is called leukorrhea, by the way, which is normal, and that shows a good lactobacillus. Urinary frequency, which is normal unless there's pain. Any type of vaginal bleeding is suspicious. Doesn't mean it's abnormal, but it's suspicious and we need to investigate. People have vaginal bleeding because of implantation, because of sex, because the cervix gets very vascular, and anything that touches the cervix may cause it to bleed. So during penile intercourse, we could have vaginal bleeding, so postcoital bleeding. She could have a threatened abortion or a threatened miscarriage. She could actually have a absolute miscarriage, varicosities, and then please read through some of the danger signs which are on page 279 to 280. We're not going to go through those right now. Education, again, we want to talk to her about the danger signs during her pregnancy. We want to talk to her about nutrition. We want to talk to her about increasing her fluid intake, water specifically. We want to talk to her about appropriate exercise. Keep the heart rate below 140 beats per minute, please. Don't go out and start doing high intensive exercise now that you're pregnant. We want to talk about the signs and symptoms of preterm labor. We want to talk about what she should expect for fetal activity. Baby starts moving between the 16th and 18th week, but that does not mean she's going to feel it moving all of the time until she's probably over 20 weeks or so, and then the baby, we'll be able to ascertain that feeling. We should talk to her about bleeding and what to do if she starts to bleed and who she should call. Not to ignore it, because just because she had sex last night, she's got a little bleeding, she probably thinks it's postcoital. Let's be sure. Let's have her talk to somebody. We want to talk to her about preparing for childbirth, about parenting. Does she know she has choices? Who is she going to have deliver the baby? Where does she want to deliver this baby? Who does she want with her? What does she need to learn? So let's educate her on all of those things. Some of the complications of pregnancy, we've already talked a little bit about ectopic. Ectopic, of course, happens when there's been scarring in the tubes, and that can because of a chlamydial or gonorrheal infection or any other STI. Again, we treat ectopics either chemically or surgically. Chemically or surgically. Chemically with methotrexate if it's early enough. Surgically where we actually remove the pregnancy and the tube. Abortion. Abortion can be threatened, elective, or spontaneous. Doesn't matter what the cause is, it's still one term, umbrella term we use, abortion. I just caution you when you're talking to your patients, if she's had 5 miscarriages, we don't want to go in there and say, well, I see you've had 5 abortions. She's going to take great offense to that. So we want to be very cautious when we're talking to patients. How many losses have you had or miscarriages, or let her tell us that was actually an abortion, that she elected to terminate the pregnancy. There are different kinds. There's threatened, there's complete, there's incomplete, missed abortions, and I have some pictures to show you of that. A molar pregnancy. Molar pregnancy is where a group of cells the sperm and the egg got together, but for some reason there wasn't a nucleus in one or the other, and so we continue to have cell division, but those cells do not have nucleus as well. This can be assimilated with the idea of cancer. The cells kind of grow abnormally rapidly, so patients are going to have higher levels of HCG. They're going to have higher problems with nausea, vomiting. Their uterus is going to grow very rapidly. And so this is a dangerous situation, and if it's not checked, most often this will resolve itself. It will abort itself. But if it doesn't, it can cause a uterine rupture if it grows so rapidly. The other problem with it is if it doesn't completely resolve, pieces of this can break off and metastasize to other parts of the body and can cause a continual growth, which then leads to a cancer and can kill women. So it's called trophoblastic disease. So we manage these patients for an entire year post-delivery or post-resolution of this molar pregnancy, and we watch their HCG levels for an entire year to ensure that it hasn't migrated to another part of the body to cause additional problems. The risk is once she's had a molar pregnancy, she may again have one, so we want to be doing early ultrasounds. Incompetent cervix. Incompetent cervix is where the cervix will not hold the pregnancy in place, and for some unknown reason it starts to dilate, and she will deliver her baby with hardly any feeling. Will not have any complications. Incompetent cervix is corrected surgically with the second or third pregnancy. Placenta previa, I have some pictures to show you of that. It's where the placenta embeds itself over the cervix. So as the cervix is opening for labor, the first thing that it'll deliver is the placenta. This is extremely dangerous. There are different kinds of previa, and we'll talk about that when I show you the pictures. Placenta abruption. This is a little different than placenta previa. Placenta abruption, it actually tears away from the uterus. Preterm labor, I would encourage you to watch the video that's embedded in the module. It's from the March of Dimes, and it's a very nice explanation of everything. It's as if we're talking to patients, but it'll give you all the information you need to help you with preterm labor. PROM stands for premature rupture of membranes, meaning she's ruptured membranes before she starts contracting. PPROM is preterm premature rupture of membranes. So she is rupturing her membranes before she labors, but she's also too early in her pregnancy. Both come with some complications that we'll talk about, and the biggest complication to rupture of membranes is infection, because now there is no barrier of any kind, and now this baby's wide open to the external environment. Preeclampsia, eclampsia, and HELP syndrome. DIC, which you have been affiliated with. And then systems issues. If you have any cardiac, respiratory, or immune issues, it can translate to more complications in pregnancy, but we're not going to spend a lot of time on those because oftentimes those issues are taken care of in a tertiary care center, something that you will never see at Monroe or Waterman or any other smaller facility that has obstetrical care. And diabetes, which is incorrectly spelled there for you, is another huge problem that we're going to talk about. Let's take about a 5-minute break before we go into these complications, and then we'll come back for part 2 of our module. Okay, I'm back. I needed to just stretch my legs for a second. I hope this is helpful to you. If it is not beneficial, I do need to have some feedback. If you feel these are too long or we need to bring them up a little bit more, I just don't want to flood your email with too many different things that you then will not be able to see or use, or it kind of gets lost in all the emails. So just let me know what you all are thinking or wanting or needing, and I'm happy to try and help you out as best I can. Please understand that these lectures are a supplement to the reading. You cannot not do the reading and use this as your only source of information. I am highlighting. I'm probably not going into a lot of detail. So here's some pictures of the ectopic and abortion and a molar pregnancy. The left-hand corner above is your ectopic, where you can actually see the fetus is growing inside the tube there. That's a little bit more dramatic than it probably is, but it gives you an idea. And if this uterus, if that tube ruptures, it's very vascular, remember, and she can sanguinate. The bottom picture is an actual picture of a molar pregnancy, and you see it's just a conglomeration of a bunch of cells that are developing and growing, and they're growing very rapidly, and that will usually spontaneously deliver on its own. But if not, we need to identify, and we would identify because she's going to come in with pain because the uterus is growing so rapidly. When we draw HCG levels, serum levels, we're going to see that those levels are very high. She's going to have a lot more nausea and vomiting than what she would normally have. So when someone comes in with hyperemesis, excessive nausea and vomiting with an electrolyte imbalance, we're going to go looking for this. The other picture you see, the bigger picture, are the different kinds of abortions or miscarriages. The top left is a threatened abortion where she's having bleeding. The key with all of the abortions or miscarriages is that they all come with a common theme of bleeding, and many come with cramping. The next one, so the first one to the left is an incomplete, or I'm sorry, a threatened, where she's got a little bit of bleeding, but the cervix is closed and she probably won't deliver. The one next to that, the one on the right, is an incomplete or inevitable, where the cervix is wide open, membranes have ruptured, and she's going to lose this pregnancy. The one in the middle is a complete abortion where both the baby and placenta have been delivered intact, so we don't have to go in and do any type of D&C or D&E to evacuate that uterus. To your left bottom is an incomplete where she lost the baby, but she hasn't delivered the placental tissue yet, and she has to deliver that or she's going to get an infection. And the one on the lower right is a missed abortion where the baby is a demise. It has died inside utero, yet she doesn't have any signs or symptoms of a loss. Once we recognize that, because we can't find heart tones, once we recognize that, we usually give moms the option to wait a couple more days for a spontaneous resolution, or we will go in and do a evacuation of the uterus, again to protect her from DIC, infection, and bleeding. This is an incompetent cervix. Again, you cannot identify this or diagnose this with the first pregnancy. She usually had to have a loss, or the cervix has to be pretty well open and the baby's still intact, as you can see here. But what we will do with the picture on the right is do a stitch. And there's two different kinds of stitches. There's a McDonald stitch and a Shirokar stitch. You don't really need to know that. Just note that the stitch around the cervix will stay in place until about 37 weeks gestation when we consider the pregnancy at term. And they will go in and remove that stitch and then allow her to labor. Placenta previa, placenta abruption. The top picture is the previa. These are the 4 different types of previa that you might see. The common element of both is vaginal bleeding. What's different about them is placenta previa has painless bleeding and abruption has painful bleeding. What is the treatment? Conservatively, we try to manage. We just try to watch and wait, especially if she's at a preterm status. If we cannot be conservative, and if the placenta is completely over the cervix, as you see in the upper left picture, she will have to have a C-section. With the partial previa, she'll probably have to have a C-section. With the marginal and low-lying, we're going to watch, and we're going to decide, watching her dilate, if indeed she has to have a C-section or if we can do a vaginal delivery. But the common treatment with the placental previa is to do a C-section. If she stops bleeding, We will tell her, and if she's preterm and she stops bleeding, we'll tell her to be on bed rest and pelvic rest. Nothing in the vagina. And hopefully we can hold the pregnancy a little bit longer. Every day close to 40 weeks is a better day for the baby. The bottom left corner picture again is your abruption, where the uterus is actually, the placenta is tearing away from the uterus. And what would cause that to happen? Drugs, smoking, hypertension, baby's too large, trauma to the abdomen, anything that can have an acute insult to the placental perfusion can cause it to break away. So if a patient comes in bleeding, we're going to do an ultrasound because that's the only way we can find either one of these problems. So that's the common treatment as well, is an ultrasound and then probably a C-section if it cannot resolve. And how do you recognize it? Patient comes in bleeding, complaining of some abdominal pain and bleeding, and our nursing interventions, of course, is bed rest immediately, put on the fetal monitor immediately to identify the viability or the status of the baby, the fetal well-being. We're going to notify our physician. We'll start an IV to try to replace some of the fluids, and then we will make a plan. Based on what he sees on an ultrasound, we will make a plan as to whether we have to do an immediate ultrasound, C-section, or if we can wait and allow the baby to grow. Preterm labor. The definition of preterm labor is pregnancy from 20 weeks to 37 weeks going into labor. Now, there's labor and preterm contractions. Labor is defined as regular uterine contractions with cervical change. If there's no cervical change, there is no labor. But your definition for preterm labor then is regular uterine contractions with cervical change prior to 37 weeks, and indeed the cervix is at least 2 centimeters dilated or 80% effaced. Signs and symptoms, women will complain of different things. Urinary frequency, increased vaginal discharge, cramping, pressure, back pain. Any one of those things could be a trigger that something is changing. Nursing intervention, if she presents to you and you know she's preterm, you're going to get her in bed. You're going to get a fetal monitor on. You're going to start fluids. The most common cause of preterm labor is dehydration, first of all, or contractions. There's dehydration. Please understand something, and if I don't say it now, I'll probably say it again next module, is that the uterus is the large muscle. Large muscles require 3 things from you: food, fluid, and rest. And when we don't provide those things, it's going to act against us. It's going to fight, and it'll start to contract. In Florida, women become dehydrated very quickly, and so they get a little preterm contractions going on because they're dehydrated. We allow someone to contract long enough, she will start to dilate. So we want to stop those contractions as quickly as we can, both for the uterine muscle problem as well as every contraction is a possible, I repeat, possible hypoxic event for the baby. Because if the uterus is contracting, the perfusion is decreasing to the baby. So dehydration is one big reason. The other is a UTI or STIs. So some type of infection is another big cause of preterm labor. And sometimes we just never know what's causing it, but we look for those things first. So I'm going to send a urine to the lab. I'm going to start either an IV fluid or give her some fluid PO bolus. Whenever we start IVs in labor and delivery, we're usually using lactated ringers as the drug of choice. And we usually give a 500 milliliter bolus. Remember, these are young, healthy women. Their cardiovascular systems can handle the bolus of fluid without any problem. What labs? Again, we already talked about the fact that we're going to send off a urine. I'll probably do a CBC just to ensure that she's not anemic as well. In addition to that, there are some preliminary screening, not diagnostic, but screening labs I can do. A fetal fibronectin is a Q-tip that we place in the vagina, and we can get some cervical mucus, and there's an enzyme that is released, and if we note the enzyme, the fibronectin, she's at risk for preterm labor. Doesn't mean she'll have it, she's just at risk. The other test that might be done is an ultrasound for cervical length. How long is the cervix? A normal cervix, non-pregnant, is anywhere from 3 to 4 centimeters in length. When it starts to shorten, we can think that she's at risk for preterm labor. So if she has a short cervix, a positive fetal fibronectin, and she's contracting, she may indeed actually go into preterm labor. Those tests should be done prior to a cervical exam before we stick our fingers in there to identify if she's dilating or not. Most of the times the orders will read bed rest, fetal monitor, get a urine, start some fluids, and then begin the medication regime. One of the tocolytic medications is terbutaline or breathine. It's a dilator. So if I can flush more fluid to the uterus, it should relax. Terbutaline is a sub-Q fast-acting medication that causes maternal tachycardia. So we check mom's pulse before we give it. This is a black labeled or danger drug because it has caused some cardiac dysrhythmias and cardiac problems. We only give up to 3 doses sub-Q, and if that is no longer working for us, we will move on to the next drug of choice. The next drug of choice, after we have given fluids and terbutaline, is to give magnesium sulfate. Magnesium sulfate is a smooth muscle relaxant. It causes the uterus to relax. It's given IV, and we give a 4-gram, may I repeat, gram bolus of magnesium sulfate, and then we put her on a 2-gram maintenance dose. The side effects of magnesium sulfate are hypotension, or decrease in blood pressure, decrease in muscular activity, so we're going to check DTRs. She's going to get flushed, very hot. She might have a little thick tongue when she's talking. So we need to be checking her vital signs. She's also going to relax her renal vessels, so she may pee off a lot more fluid as well. So she might become more dehydrated. So we're going to have to watch for that. So preterm labor, rest, fluids, send some labs, get her on a fetal monitor, see how often she's contracting, get your fetal fibronectin, do your pelvic ultrasound, check her cervix. If she's still closed, we know she's not in preterm labor. She's just contracting, and we want to correct the contractions. If we do decide to release her from the hospital after we've done all these interventions, she should go home with the education pelvic rest, nothing in the vagina. Please understand that semen has a prostin in it, which is very much like the prostins we use to start labor. And the activity of intercourse can cause the uterus to contract. So we don't want to do either of those things. So pelvic rest, bed rest for preterm labor until she gets to be 36 or 37 weeks gestation, where we're comfortable with, and indeed she delivers, the baby will not have any difficulties. Preeclampsia, it's a hypertensive disorder, but that's only one facet. Please understand that in a preeclamptic situation, it isn't that she has high blood pressure, it's that her vessels and her muscles are so tense that it causes her pressure to rise. So it's kind of like a side effect of this tension, because what we're trying to avoid are seizures. Eclampsia is seizures in pregnancy. We're trying to prevent that. The signs of preeclampsia are, of course, high blood pressure or hypertension. The thing that distinguishes this from any other hypertensive disorder is the proteinuria. She has protein in her urine of +1 or greater. And edema. And we're not talking about the normal pedal edema that we see when people are walking around all day. We're talking about facial edema, full body edema. She just wakes up and she feels like the Michelin Man, because most people, when they wake up after having an edema episode, it's resolved. But these women wake up with edema and they look sick. They don't feel well. She's also can complain of visual disturbances and epigastric pain. Please understand that preeclampsia encompasses 4 organs: the brain, the heart, the kidneys, and the liver. So the brain, she's going to have headaches and visual disturbances and edema. The kidney, she has the edema and the proteinuria. The liver, her liver enzymes will increase, and in fact to the point that she can have a ruptured liver if we're not careful. And epigastric pain is also part of the liver. And what else? And the heart, of course, because we can have issues with hypertension. Subjective signs, she's going to complain of blurry vision, headaches, swelling, and epigastric pain. Treatment, again, bring her into the hospital, put her on her left side. Left is best. It improves the perfusion to the placenta. Remember, if she's hypertensive, we've decreased the perfusion to the placenta, which means that the baby is not getting the proper nutrients and oxygen right now. If we have chronic hypertensives that are not taking care of themselves, not taking their medications, babies will be small. If she becomes preeclamptic, if we don't correct it, babies will be small as well. The difference is, has it been happening chronically or has it been happening acutely? And we'll talk about the results to the baby in just a few minutes. So what is our treatment? Again, we bring them to the hospital. We place them on their left side. We put a fetal monitor on them and we start IV therapy. However, the difference between this and preterm labor is we do not give a bolus. She cannot tolerate this increase in fluid. She already has too much extracellular fluid or interstitial fluids. So we're going to titrate her fluids very, very carefully. We will start magnesium sulfate again, but this time it is to relax the vessels and the muscles around the vessels. So in your Davis drug guide, it claims that magnesium sulfate is an antihypertensive drug. I have issues with that, but I'm not the expert. But I say that it's a side effect of magnesium because it relaxes the vessel, hence it'll bring the pressures down. Doesn't always work, but it can possibly bring pressures down. So we're going to take vital signs every hour. We're going to check DTRs every hour. We're going to put in a Foley catheter to check output every hour. And we're going to check her protein. We're going to check her LOC, her level of consciousness, and her ability to communicate with us, because magnesium and preeclampsia can cause problems. We're going to pad the side rails possibly, so that if she does have a seizure, she will be safe. So this is not a benign problem. The only cure for preeclampsia is delivery of the placenta and the baby. And then even then, we keep magnesium sulfate on board or infusing for another 24 hours post-delivery. In addition to that, and in addition to the medications for preterm labor as well as preeclampsia, if this patient is less than 34 gestation, we're also going to give her betamethasone. Betamethasone is that drug to help lung maturity. I apologize, I forgot that with preterm labor. In addition to this terbutaline and the magnesium sulfate, we might give betamethasone to accelerate lung maturity. It's a steroid that we give to mom. So what's the fetal risk in preeclampsia? It's called IUGR, or intrauterine growth restriction, where the baby is too small, and I will show you some pictures of that. The other big problem we need to talk about is diabetes. Diabetes comes in many flavors, type 1, type 2, and gestational. I know you've learned about type 1 diabetes, and that is where there is no insulin available to counteract the blood sugar or to help facilitate the sugars into the cells. Type 2 diabetes is usually diet-linked, does not require insulin necessarily unless that gets out of control as well, but we see it with obese patients, and we're seeing it more and more in children now because they're also obese, and we're getting more and more young children with type 2 diabetes. Gestational diabetes is significant or relevant only to pregnancy, but it responds the same way. Remember that pregnancy itself is a higher glucose time. Now, let's go back. Type 1 diabetes, no insulin available. We know that there are perfusion problems with insulin dependence. Poorly controlled diabetes causes problems to the eyes, to the kidneys, to the liver, to the heart, to the brain, to wound healing. So it is a perfusion issue. Once we introduce insulin, diabetes has become a perfusion problem. Now, where is perfusion a huge issue? If you've said placenta, you are correct. So, Type 1 diabetes means that she comes into the pregnancy with a perfusion issue. We know that that developing baby during the critical period needs proper, pristine, so to speak, perfusion. And when we don't have that, we're going to have an insult to that developing baby. So type 1 diabetes, the biggest risk to baby is fetal anomalies. And of the fetal anomalies, the most prevalent is cardiac issues. And of the cardiac issues, the most prevalent is a VSD, or ventricular septal defect. They also come with skeletal defects or central nervous system defects, but the one we see most often is fetal cardiac issues. Diabetes in pregnancy is unique in the fact that because pregnancy itself is an increase in BMR, basal metabolic rate, you are growing another person inside you. Your body is churning things rapidly. Your insulin requirements in the first trimester decrease because you're burning off those sugars. But then in the second and third trimester, they increase very rapidly. And so we watch these patients very closely. We are seeing them every week to monitor blood sugars and to ensure that we're adjusting insulins as necessary. A lot of these patients do not deliver. That's not true. They do deliver in our hospitals around here, but under very close vigilance of an insulin drip and sugar drips. So type 1 diabetes is unique in the fact that it is linked to fetal anomalies. If you come to my office and tell me that you have insulin-dependent diabetes, I would be setting you up for early ultrasounds and an early fetal echocardiogram to look at the baby's heart, since I know that that is the biggest risk. Type 2 diabetes is a diet controlled, and if she can control it in her pregnancy, no risk. But if she requires insulin, and most often she will require insulin in pregnancy because of the higher sugar loads in pregnancy, now she becomes a perfusion issue. Now she becomes a watch the placenta growing issue. But it has no link to fetal anomalies. Gestational diabetes is a diabetes that occurs only in pregnancy, and we usually don't find it until about 28 weeks, 26 to 28 weeks. And usually it's managed with diet and exercise and just knowledge to the patient. But if indeed it becomes out of control and she requires insulin, then again she becomes a placental perfusion issue once again. But there are no anomaly links because we don't have this problem until the baby's fully developed. Remember, 12 weeks, baby's fully developed. 8 to 12 weeks, baby's fully developed. As long as there's no insulin requirement, we try to treat diabetic patients, gestational and type 2 diabetics, as any other normal pregnant patient. But once she adds insulin, we know that this becomes a perfusion issue, so we have to monitor this patient a little closer. And we do what we call non-stress tests, which we're going to talk about in the next module. Non-stress tests to ensure that the baby is getting the perfusion and the oxygen and nutrition that it requires to survive and to grow. One of the biggest risks to diabetic babies, because they get a lot of sugar, remember sugar crosses the placenta but insulin does not, is that they get very fat. But it isn't that they get total body fat, they get fat in their trunk. Hence the word macrosomia, large for macro, somia for body. They get large bodies, and their head and their chest are the same size. We talked in orientation that the head is always bigger on the body, bigger on the baby than the rest of the body. But in a macrosomic baby, that is not true. Hence the risk for birth injuries, trying to get the baby out. So macrosomia is a big risk to babies of diabetic moms that are out of control. Babies will make their own insulin. Hence the second risk, really there's twofold. The second risk is that once the baby's born, they're going to have a hypoglycemic attack. Their blood sugars are going to crash and burn because they've been getting all these sugars from mom, and so I'm making the insulin to counteract that. I keep making the insulin, and then when I'm born, there's no more sugar, and I'm still making my insulin, and wow, I'm going to crash, and I become hypoglycemic. Babies who are hypoglycemic are jittery, lethargic. They will go into a coma and they will die if we don't correct it. So we're very, very vigilant about any baby that is greater than 8.5 pounds or 4,000 grams. Macrosomia is defined as a baby 4,000 grams. Or 4 kilograms, I guess you could say. The other part of babies that have an issue, other than the macrosomia, is lung immaturity. Lungs on babies do not mature as well as normal or healthy pregnant babies. And so we have to monitor that as well and ensure that their lung maturity is greater. Polyhydramnios is another issue we see. Remember, I already mentioned that. Too much fluid around the baby is called polyhydramnios, and we see that in diabetes. So if you note that you're getting bundle height greater than gestational age, and you're not feeling that the baby's really big, we go to look for the polyhydramnios. These are pictures of some of our macrosomic babies. The baby on the top left is a macrosomic baby, and you see it looks like a little sumo wrestler. They're not pretty babies. The picture on your lower left, those babies are the same gestational age. The baby on the top right is a jaundice baby now. That's another problem because with diabetes, the blood gets a little more viscous, which means there's more red blood cells to break down. The byproduct of a breakdown of red blood cells is bilirubin. These babies cannot excrete their bilirubin yet because their liver's immature. It cannot metabolize it. So we get babies with greater risk of jaundice. And the baby in the lower right-hand corner, of course, is a baby with poor lung maturity, macrosomic, with poor lung maturity, who's having some troubles regulating his temperature and troubles breathing. Other issues that we should be talking a little bit about is your obesity. Obesity is a problem. These people tend to then be gestational diabetic or have some other issues. They also grow bigger babies that don't fit well through that pelvic outlet that we talked about. So we caution people about that. And it also means that they're not getting the proper nutrition. They're getting poor nutrition, which isn't helping the development of their baby. Adolescents have their own subset of issues, maturity levels, eating disabilities, activity, risky behaviors, all kinds of things that would be counterproductive for a healthy pregnancy. Surgery during pregnancy is usually linked to the anesthesia risks. Cancer during pregnancy, of course, linked to the chemotherapy or other treatment modalities that we would want to offer. Substance abuse, again, there's a whole subset culture of people who use substances, drugs, alcohol, smoking, and finding unique ways to get a hold of the drugs. Women that are on drugs that are now on methadone to try to clear the drug, but take inappropriate methadone. Again, these babies then result in what we call neonatal abstinence syndrome, NAS, neonatal abstinence syndrome, and that's a whole withdrawal program in itself, and we're seeing more and more of that. Poor nutrition, which is going to lend itself to IUGR, and I'm going to mention IUGR here in just a moment. And of course, the other issue is intimate partner violence. Please understand, domestic violence or partner violence is huge everywhere, but in pregnancy, it escalates because now there are two people that are vulnerable instead of one, and a mother will do just about anything that is requested of her to protect her baby. So there are some issues there, and if we identify it, we need to report it, and we need to also help her then work through what her choices are. Let me go back briefly to IUGR because I believe this is the last slide. Oh, it's not the last slide. Let me see. We're second to the last slide. IUGR, intrauterine growth restriction. This is caused from a perfusion issue. Perfusion to the placenta has been decreased due to smoking, due to drugs, due to hypertension, due to some other disease process or an infection. Some reason there is not a proper or adequate perfusion to the baby, and the baby has intrauterine growth restriction. The babies that you see in this picture are both the same gestational age. The one to the left is IUGR, and the one to the right is normal and healthy, possibly even a little macrosomic, but because they're so diverse, it's hard to tell. So IUGR comes in two flavors, as I like to say. Please write these down. There's asymmetrical or symmetrical. Asymmetrical is the preferred abuse or insult. Asymmetrical is what we used to call head sparing, the brain being the most valuable organ right now. We want to protect the brain. And so the head is about the normal, smaller, but normal size, but the rest of the body is small. And you can see on this baby here, he has no additional fat on him anywhere. He has all the parts, everything is functional, but he just doesn't have the fat to help support the first few days of life. So asymmetrical IUGR is the preferred IUGR because the head has been spared. Symmetrical, and because of that was an acute insult, preeclampsia, a couple shots of cocaine, I just started on drugs, I just started smoking, I just stopped eating, whatever, but it's an acute insult to this baby's perfusion. Chronic insult, symmetrical IUGR, means everything was affected. So the baby is small for gestational age or just tinier, and there may even be some cognitive deficiencies that we will not be able to recognize until the child starts to get older. So every time we meet a pregnant woman, we should be talking about, first of all, is the baby moving? How are you eating? What kinds of foods do you eat? What type of exercise do you get? Do you feel like you're breathing and breathing deep? Exercise is good because it causes you to breathe deeper, giving you more oxygen to the placental bed. Are you having any pain, any difficult, safe sex? I mean, these are the questions we should be asking to help protect. Are you smoking? Are you drinking? Do you know what that's doing to your baby? I mean, would you hand a baby a cigarette? The answer is always no. And yet that's what you're doing. Would you hand your baby cocaine? Well, absolutely not. But that's what you're doing. And that's what I think there's the disconnect when we're actually pregnant. So IUGR, two kinds, symmetrical and asymmetrical. The very last slide I'd like to share with you is antepartum assessments. And I must say I did not go very deeply into Chapter 10, which is talking about promoting a healthy pregnancy, so I do expect that you will read through that and learn as much as you can. And if you have questions, please ask. Antepartum assessments, part of it is some diagnostics that we want to do. Who's at risk for needing additional testing? Well, one we've already identified is the diabetic patient who's on insulin, right? The preeclamptic patient because there's poor perfusion to the placenta. We can't see the placenta, so we're going to have to test it. A mother or a woman over the age of 35, she needs additional diagnostics, and the additional diagnostic would be an amniocentesis to look at the genetic screen. Now, she can refuse that, and that's fine, but we need to counsel her. So we would be sending these patients, or we would send the woman over 35 years of age to a genetic counselor. We would send someone with a history of genetic linked problem in their family to a genetic counselor, or someone with a baby that they've lost because of the questionable chromosome link, we would send to the genetic counselor. So there are groups of women that we would want to get preconceptual counseling and or genetic counseling early on in the pregnancy. One of the additional assessments we would do is what used to be called MSAFP, maternal serum alpha-fetoprotein, which is now called the quad screen. And I think it even has another new name because they've increased the number of diagnostics that we're doing to look at this. This is a screening test only. It is not diagnostic. It represents a possibility of something. When we get high levels of MSAFP, we can think open neurotube defect, meaning that there's a spina bifida or there's an opening into the spinal tract somewhere. And depending on where the lesion is located along the spinal tract will define how significant the problem is. So high levels of that test give us link that she has an open neurotube or an open cavity in the body problem. And we can identify a lot of that with an ultrasound. The other thing is we want to identify dates with an ultrasound if we get an abnormal finding, because this test has to be done between the 15th and 21st week. The low levels on this test give us a hint that there's some Down syndrome. or some other chromosomal linked deficiency that we would identify with an amniocentesis. Ultrasounds. Ultrasounds can be done in the first, second, or third trimester. I would ask that you kind of look to try to figure out why we would do ultrasounds at the different trimesters and what the benefit would be. Fetal fibronectin we've already talked about. Cervical length we've already talked about. Those are screening exams for preterm labor. Once a patient is about 26 to 28 weeks, a baby's in a routine of movement. They move early in the morning, they move late at night, or they move whenever mom decides to sit down and not do too much. So fetal kick counts are something we can ask her to do, especially a woman who's at risk, diabetic, hypertensive, autoimmune problem, poor nutrition, smoker, uses drugs, uses alcohol. Anybody that we're suspicious of the fact that they have poor perfusion, we would ask them to do fetal kick counts. Everyone should do them, but these people most specifically. Lays on her left side because we know perfusion's best on the left, right? Lay her on her left side, put her hand on her tummy, and every time the baby kicks, she should put a little tick mark on the page. She needs 5 kicks in 1 hour or 10 kicks in 2 hours to be deemed successful and that the baby's fine. However, she's got to eat something. If she doesn't eat before she does this test, the baby's not going to move. If you haven't eaten in a couple days, you're pretty lethargic too, and it's hard to get you motivated or even out of bed. The next test is called a non-stress test. You need to have a fetal monitor to do this test. I would ask that you refer back to the fetal monitoring lecture that's been given to you. We place someone on a monitor. It takes 20 to 30 minutes. The goal is that when I run down the hall, my heart rate races or goes up. So if a baby is active in utero, his heart rate will increase. So I'm looking for accelerations or increase in fetal heart rate with movement. I need to see 3 accelerations in 20 minutes to deem this a reactive NST, or the baby is reacting to his environmental change. And the increase has to be 15 beats per minute over 15 seconds to be deemed reactive. So again, a non-stress test is going to be done for any diabetic on insulin, someone who's preeclamptic, someone who has hypertensive disorders, someone who smokes, someone who uses drugs, someone with poor nutrition and the baby's not growing. Any risk factor to the baby, we're going to do non-stress tests. These are non-invasive, don't hurt the baby at all. They're just time-consuming. A CST requires Pitocin and contractions, and I'll let you read a little more on that. We don't do that much. And the very last thing is a biophysical profile. This is an ultrasound. It is a measuring tool to look at 4 parameters. One of the parameters is amniotic fluid index. Another parameter is fetal activity, fetal tone, and fetal breathing movements. No, the baby is not breathing in utero, but his chest rises and falls, so the intercostal muscles are exercising in preparation for the time he's going to take that breath. They get a score of 2 for each of those parameters for a total of 8. When they fall below the 8, we start looking at how we're going to manage this patient. Okay? Biophysical profiles are done at any time a non-stress test is not reactive. Baby does not respond to environmental changes, so he is not healthy. So if we have a non-reactive NST, or if I have a patient that is over 40 weeks gestation, the placenta starts to age, and I want to watch her a little closer, so I'm going to do a biophysical profile then as well. It's a wonderful tool. It is not necessarily diagnostic. It's a screening test, but it gives me a piece of the puzzle so that I will know to continue to monitor this baby. Worst case scenario in the world of pregnancy is that we have sudden, unexplained fetal demises, and it still happens. Mom felt the baby all day yesterday, Doesn't feel them too much today. Now I don't feel them at all. I better call somebody. By the time you get through, they tell you to go to the hospital. Oh, I got to take a shower. I got to shave my legs. I got to get a ride. I get to the hospital 2 hours later. The baby's dead. Baby's dead. There is no excuse. We have got to educate our patients and our mothers about babies have to be active. Active babies are healthy babies. Babies that are not active are not healthy. Now that's not to say that the baby's going to move 24/7. They sleep a lot. Babies when they're born sleep 18 to 20 hours a day. They're going to do the same in utero. So they're still going to have some sleep periods. But when they're supposed to be active, or when you expect them to be active, or if they're not responding to your activity, then you should be questioning what's going on. What has happened to that environment inside that I cannot see, that I can intervene? So non-stress tests, biophysical profiles, and is your baby moving? Is the fundus growing? And do I have heart tones? Thank you all very much, ladies and gentlemen. I know this was about a 2.5 hour, or give or take minutes there, of a program. I hope it was helpful. If at any time you do not feel that these are appropriate or helpful or beneficial, whatever, please let me know, and we'll change the format or we'll change something, all right? So I'll be embedding this in your Module 2 announcements. Thank you.